All right, cool. All right, well, I'm going to get us started. So welcome to our opioid education workshop. We have several speakers. I am opening us up. So I'm Zoe Morrow. I run the Drug-Free Communities Grant in Holliston through the Holliston Drug and Alcohol Awareness Coalition. And our partners on this are Youth and Family Services, the Fire Department, the Police Department, and the Center, previously known as the Senior Center, where we are hosting. So our objectives today are to learn who HDAAC is, if you haven't heard of us, and how to get involved, describe the history of the opioid crisis and settlement, discuss what opioids are and how to use them, explain how to safely take, store, and dispose of opioids, defining opioid use disorder and addiction, identify an overdose, when and how to use Narcan. We'll also be giving out Narcan. Describe addiction treatment and what help is available, especially locally, discuss prevention in the settings of opioid use disorder, and we'll also have Q&A. So starting off is who HDAAC is. Stay close. So this is our mission and vision and some of where our money comes from and what we do. But basically, we're a coalition that was founded by someone in recovery about 10 years ago. We have drug-free community funding from the federal government about 3 years ago. And we do a lot of prevention work with our high school students. We do a lot of community building with Holliston, and we utilize the 12-sector format. So we have lots of representatives from different sectors of the community: law enforcement, schools, parents, youth, businesses, a whole plethora of people. So I think I turn it over to our first speaker, Karl, Dr. Liebermann. So switch off.
All right. Hello, I'm Karl Liebermann. So basically, the opioid crisis was driven by overprescription of opioids in the 90s and 2000s, and I'll do a deeper dive into that in a minute. In 2021, there was a $26 billion settlement that was reached with major opioid distributors. These settlements funds are required to support treatment, prevention, and safer opioid distribution practices. The companies also had to agree to make changes to be safer and more aware how they distribute prescription opioids. And how we got from the original overprescription of opioids for here is basically there were 4 waves of the opioid epidemic. The first wave of the opioid crisis occurred when there was a major increase in opioid prescriptions in the 1990s. This was driven by aggressive marketing of opioid pain medications by pharmaceutical companies, the minimization of risks of opioid addiction, and government-led incentives to minimize pain. There was pain as the 5th vital sign. Prior to the mid-90s, opioid pain medications, and then they include medications like oxycodone, Vicodin, OxyContin. They were not commonly prescribed for like chronic pain. Important to note that between 1996 and 2011, the sales of the opioid pain medications correlated well with deaths from opioids and intakes to admission treatment centers. So there was a direct correlation between the amount of prescriptions, opioid deaths, and opioid addiction in general. The second wave started around 2011. And when that happened, there were basically prescription opioids started to dry up for several reasons. There were more regulations. People started to realize these, for a lot of reasons, the less prescriptions of opioids. What happened, though, it didn't change the amount of addiction. And so the street oxycodone, OxyContin, they became less available, higher cost, and then there was inexpensive heroin available through the dealers. So the second wave involved illicit heroin. One study showed that 4 out of 5 heroin users used a prescription opioid pain medication first. The third wave began In the middle of the 2010s decade, when heroin was replaced with fentanyl on the illicit drug market. And important to note about fentanyl, it's a lot more potent. A typical daily use of heroin is between 400 to 500 milligrams per day, whereas fentanyl, which is used in hospitals, a typical therapeutic dose is between 50 to 100 micrograms per dose. 2,000 to 3,000 micrograms of fentanyl, which correlates to 2 to 3 milligrams of heroin, can be deadly. The fourth wave is now, it's about 4 or 5 years. Right now, the illicit fentanyl is often mixed with stimulants, including methamphetamine, mixed with cocaine, mixed with benzodiazepines, mixed with xylazine, which is an animal tranquilizer. So they combine to make the fentanyl even more deadly. And many opioid overdose deaths show a mixture of several compounds with stimulants as a major factor. Impact today, opioids cause about 75% of US overdose deaths annually, over 80,000 in 2022. Middlesex County had 301 opioid-related deaths in 2023, the most in Massachusetts over the last 8 years. Holliston recorded 10 opioid-related deaths between 2016 and 2021, but 0 in 2022 and 2023.
And we just wanted to make note about what's going on with Holliston settlement dollars. So after the settlement happened, all of the states, including a lot of like towns and cities within those states, received money and are still receiving money. So as of July 1st, 2024, almost a year ago, Holliston has received about $150,000. And we will continue to receive about $40,000 annually for 18 years. And at the May town meeting in 2024, Holliston or HDAAC, the coalition, secured 50,000 of that, so about a third. And of that money, 15,000 was directed to the Community Action Fund for residents directly impacted by opioid use, to be able to use that for their finances. That could mean helping them go to a center for treatment. It could be helping them get rides to AA. It could be boarding an animal while they're out at a treatment center or something like that. So we're open to hear from the community on how to use those funds and if anyone is looking for assistance. Always looking for feedback. Some of the remaining amount has been spent on Narcan kits, speakers, workshops, and we're also doing student scholarships for any students that have been impacted by the opioid crisis. We'll be asking at the next town meeting, which is this upcoming May, for an additional 30,000, because that's about how much we've spent in the last year, so that we can start July 1 at 50,000 again.
So what are opioids? So as I mentioned before, opioids, commonly prescribed opioids, oxycodone, Percocet, codeine, morphine, Vicodin, and fentanyl. They're extremely effective in treating acute pain. Like say if one goes to the hospital with like a broken arm, or if there's a surgical procedure, they're very effective in treating chronic pain. Very effective in treating acute pain, but not so effective in treating chronic pain. They work by attaching and stimulating the opioid receptor in the brain. Based upon the potency of the opioid is the amount of pain relief that one receives from that. The downside to the opioids are that they have a high potential for misuse due to the addictive potential. High doses of opioids, in addition to the person getting a high, euphoric state, can also cause respiratory depression, and high doses can lead to deaths, particularly when mixed with other substances. Heroin is a commonly abused opioid, which is Schedule 1. It's produced illicitly, and so that one can't be prescribed. Fentanyl, which is on the street, is actually a controlled and commonly prescribed in hospitals.
I am Lois Parker. I'm a longtime Holliston resident and a retired clinical pharmacist. I come from the hospital environment where we actually did use opioids safely quite often in patient populations ranging from newborns all the way up through older populations. So I'm going to talk a little bit about being responsible in terms of storage and usage of opioids, since, as Dr. Liebermann noted, a lot of the issues around substance use disorder are related to being careful about how opioids are used and stored and prescribed. So prescribing practices that have contributed to the opioid epidemic include prescribing high doses of opioids, meaning higher than what a patient might necessarily need, overlapping opioids with other medications that can include sedatives such as benzodiazepines like Xanax and Klonopin, extended release and using long-acting opioids, and excessive quantities of opioids. You hear about oxycodone and OxyContin. OxyContin is a long-acting form of oxycodone, and it's intended to last at least 12 hours. As far as the excessive quantities go, number of studies have been done. There was recently a study done in a pediatric population, or parents of pediatric patients. They surveyed 185 parents, and they found that the average prescription was for about 20 odd doses of opioids, and the average patient used 2. I can say from my own experience, I had elective foot surgery nearly a year ago, and I was prescribed 30 doses of oxycodone, and I used 1. And when I spoke to the surgeon about this afterwards, because it really is overprescribing, he said that the average patient actually uses 3. So I said, then why are you prescribing 30? And a lot of the issue behind that is that they don't want to be bothered by patients who run out or need a prescription at an inopportune time. So prescribing excessive quantities is a significant problem. There are new federal guidelines for prescribers that try to address that. They need to consider the needs of special populations, older adults, pregnant women, patients with a history of substance use disorder, so that they really are tailoring their prescribing practices to this population. Older adults, for example, metabolize the medications differently. Most opioids are metabolized, meaning broken down by the liver, and then the kidneys are how the body gets rid of them. So an older patient's liver isn't going to metabolize those drugs as quickly as a younger person, and the same thing with the kidneys. These organs aren't as efficient as patients get older, so they typically need smaller doses of these medications. They should prescribe immediate release opioids at the lowest effective dose for no longer than the expected duration of pain to minimize unintentional long-term opioid use. Medicare actually has a new rule that the initial supply needs to be limited to 7 days for opioid naive patients, meaning patients who haven't had opioids before. So in summary, the expression that we use often is to start low and go slow. So meaning start with the lowest dose that you think is going to be effective, and then go very slowly in terms of increasing that dose. And guidelines now emphasize the use of non-opioid analgesia, meaning medications like ibuprofen or Motrin and acetaminophen or Tylenol, and non-pharmacologic pain modalities such as ice, heat, massage, and acupuncture. Dental surgery is an area where teens and young adults were often first exposed to opioids when they have their wisdom teeth out in college. And the newer guidelines for dental surgery and dental procedures, such as tooth extractions, emphasize that they should actually start with ibuprofen. But it used to be that a lot of dentists and oral surgeons were prescribing things like Vicodin fairly routinely, and that's not recommended anymore. And there are also new state-like guidelines for prescribers in Massachusetts. Prescribers have to take 3 hours of continuing education in every licensure period related to opioid prescribing, and effective March 4th of 2016. So this one has been a while. But I don't think patients necessarily know about this, but as a patient, you have a right to request less than the prescribed amount of an opioid substance, which is called a partial fill. It used to be with prior regulations that a pharmacist couldn't alter the quantity of a prescription for an opioid or a Schedule II medication. So if your prescriber prescribes 30 and you only want 10, you can ask the pharmacist to only give you 10 when he or she fills the prescription. The only downside of that is that if you decide later that you want to go back and ask for the other 20, you can't do that. You can only get the 10 that you've asked for. And there are also several requirements for opioid prescriptions. They can't be filled after 30 days. They can't be refilled. They must be prescribed electronically with a few exceptions. They require a dual signature process, which is also referred to as dual verification. And then there's something called MassPat, which is a prescription monitoring tool where pharmacists and prescribers can access a state database to monitor patients' opioid prescriptions, and you actually have the ability to access other states as well. And it's something we used in the hospital. If a patient would come in, we would verify that they were on an opioid prescription and that it was as the patient described. And you could look and see if they recently filled it in New Hampshire or another state, or if they were going to multiple prescribers. So it's a way of limiting patients' ability to sort of do what people used to call doctor shopping. So it's a way to identify excessive and inappropriate opioid prescriptions. So as far as taking and storing opioids, only take the opioids that were prescribed to you as they were prescribed. One study showed that more than 70% of patients using opioids inappropriately, meaning for non-medical reasons, get them from family and friends. You've probably heard the stories back when the actor Matthew Perry was struggling with substance abuse, which was a long time struggle for him. And he was going on talk shows promoting his book. And he said when he was using over 50 tablets a day of, I think it was Vicodin, he used to go to real estate open houses and obtain the drugs from people's medicine cabinets. So it's really important to get them out of your house, or if you're not using them any longer, and to store them safely if you are still using them. I recently had coffee with a friend and I mentioned something about having brought my leftover opioids to the box at the Holliston police station. And she said, oh, I always just hang on to them in case I'm going to need them again someday. And that's the mindset that we really need to get away from through education. Because if you need them again, it will be because a physician or a provider that you see prescribes them to you, not that because you decided that you should access your supply from a few years ago for a new injury or condition. So it's important to safely dispose of unused, unwanted, and no longer needed medications so people living with you or visiting don't take them. So you may have heard of the DEA drug take back days, which are typically at the end of April and the end of October. But here in Holliston, every day is actually take back day because the disposal unit that's in the picture, this picture was taken at the Holliston police station, and you can access that disposal unit all the time. So you don't have to wait for a take back day. And one helpful thing is on that disposal unit, they also list places in the area where you can dispose of needles and syringes if you need to. These units are also in many hospitals, as well as some pharmacies, and it's important not to throw these medications in the trash or flush them down the toilet, as they're bad for people, animals, and the environment. So as I mentioned, the drug take-back days are typically held twice a year in the spring and the fall. It's a federal program, so there's no way to know if that's going to change with some new administration people in place. But as I said, every day is take-back day in Holliston, and it's really worthwhile to take advantage of that option. The October 2024 take-back resulted in 314 tons of medications being brought back. And so it's really a way of getting rid of a lot of things when it kind of gets front and center in people's mind, and these take back days are publicized. And this is just a map to illustrate when you go on the website of the state to look for a place. I think it's actually the FDA that maintains this page, but this just kind of illustrates how many take back locations there are all over the state. So it's impossible, I think, not to find one that's at least somewhat convenient to where you live.
I just want to give a little overview of opioid use disorder and addiction. If addiction can be a bit difficult to define, and even people in the field use different terminology and use addiction in different ways. Basically, addiction occurs when the individual continues to use the substance or continue the behavior despite harmful consequences. So the more detailed definition is addiction is a chronic treatable disease in which the individual continues to use the substance or continue the behavior despite harmful consequences. The current terminology medically is to use the term substance use disorder or opioid use disorder, alcohol use disorder, and so on. It's a more specific, with a more specific definition than the terms addiction and dependence are still very appropriate to use in many situations. So opioid use disorder is a substance use disorder involving problematic opioid use that leads to significant impairment or distress. It is treatable and chronic and can affect anyone regardless of race, gender, income, or social class. It can be characterized by loss of control, compulsive behavior, harmful consequences, changes in the brain due to substance use, and is related to environmental and genetic influences. Addiction is often driven by the need to alleviate pain and suffering. So there are three phases of addiction, and this kind of gets into the brain disease of addiction. So the three phases are intoxication, withdrawal, and the preoccupation anticipation phase. So the first phase is the binge intoxication phase, and that is a pretty self-explanatory to most people. So this is when several positive neurotransmitters, including dopamine, serotonin, and naturally produced opioids rise in response to a stimulus. Initially, the substance actually has to be present. This occurs in the reward center of the brain. As addiction progresses, the dopamine can start rising in response to a trigger. In the AA terminology, they'll say people, places, and things to refer to triggers, and it does not require the substance to be present. The second phase is the withdrawal / negative affect, and basically all of the positive feelings in the intoxication phase go down. So the dopamine, serotonin, natural opioids all drop, and this affects the emotions. The part of the brain most affected by this phase is the amygdala. So symptoms of withdrawal, it depends on the substance, but in general, shakes, sweats, anxiety, mood swings, and often the way the individual self-treats is take more of the substance, and in like a withdrawal management facility, a substance similar to what the person's withdrawal is used to alleviate the symptoms. The third phase, which is what makes this a chronic disease, is the preoccupation anticipation phase. And this is after withdrawal. So even when withdrawal is complete, there are still changes in the brain that can be present for days to weeks to months. Can involve stress hormones, neurotransmitters. Common symptoms are cravings, anxiety, irritability, and these symptoms can last quite a long time. Important to note that the primary area of the brain that's affected is the prefrontal cortex, is where decision-making is important. This part of the brain is not fully formed until the mid-20s. So basically, a young person who starts an addiction has not developed the proper connections in the prefrontal cortex. And so if they're exposed to a trigger, the overwhelming amount of dopamine, it can happen to anyone, not just teenagers, but the overwhelming amount of dopamine in response to a trigger can overwhelm the decision-making process.
Good afternoon. Matt Wam, the sergeant with the Holliston Police Department. I've been with the department for about 20 years. I'm the lead instructor for Holliston, as well as 5 other surrounding communities when we talk about CPR and first responder. And I'm here to discuss this little magic drug, Narcan. So we're going to go through what we actually do in the field and what you as community members can do to help try and mitigate any kind of life lost in regards to an overdose. So I've certainly, over the 20 years, I've seen pretty much the entire spectrum of the opioid crisis, and I can say this has definitely saved lives within our community. If you are called to a scene, whether it's a family member, you come across somebody who just on the street or in one of our businesses, these are some certain signs that you're going to be looking for to see if there's a potential for an opioid overdose. The number one indicator for any kind of overdose is slow respiration, slow breathing. And that is just simply, if you look and see chest rise, that's an indication that they're breathing. At the same time, if you notice if you've ever seen somebody choking, their skin turns blue or ashen, it's an indication that they're not getting enough oxygen in their body. There's not perfusion going through their body where oxygen is actually getting to the parts of the body that need to happen. And once oxygen deprivation occurs inside somebody's body, obviously without oxygen, we're going to start to die. So the heart muscles start to die, vital organs, and then the brain. And the problem with opioids, as we discussed earlier in the presentation, is opioids attach to opioid receptors in the brain. The problem is those receptors also come into play with our autonomous ability to breathe. So I'm standing here, I don't have to think every 5 seconds, all right, take a breath, take a breath. You're sitting there, you're not thinking about, okay, I have to breathe every time. When the opioid attaches to those receptors in the brain, that autonomous ability to breathe ceases. When that stops, obviously without any kind of heroic measures in terms of rescue breathing or EMTs arriving to give breaths through certain devices, oxygen is not going to get into the body. And with no oxygen, we start talking about organ failure and death eventually. So there's a little graphic on the screen that you'll see. The little picture that's going up the person's nose this is actually the very first model that we had of Narcan, which was a 2 milligram dosage that we sprayed up a nose that we had to build in the field. But what happens is you spray the Narcan up a person's nose if you suspect that it's a drug overdose. The Narcan absorbs into mucous membranes. The Narcan actually knocks the opioid off the opioid receptor. The Narcan then attaches to the receptor, and the hope is if it's going to be a successful save for an overdose, is that the brain is just going to automatically kind of kick back in, and the person's going to be breathing on themselves by themselves. With that, it's always a reminder, if you're in a situation for an overdose, number one most important thing is to call 911, get the first responders going, where the primary responders and then the ambulance and fire department will respond as well. We have additional resources that we have in our cruisers and the fire apparatus to give the person a better chance at survival if it's a real true heavy overdose. For kind of a guideline of what to do if you're suspecting an overdose. First thing, look for your environment. Do you see any indicators that it could be somebody misusing drugs? Are there family members there that know that the person uses any pill bottles, any type of drug paraphernalia? Approach the person if they're awake enough where they can respond to your question. You're obviously gonna hopefully call 911 or stay with them. Make sure they don't fall into a deep overdose. But if they're not talking to you, you're going to try and get some sort of response from them, whether it's a rub of the chest to kind of create some pain stimuli. If they don't respond to that, obviously they're not alert enough. At the same time, you can look, as I mentioned, breathing, looking for chest rise, observe their skin to see if it's turning blue or ashen, where they're not getting any kind of perfusion into the outer layers of the skin. The general rule is if it's less than 10 breaths per minute, you should, if you have the naloxone available, you should give it to them. Anything less than 10 breaths per minute and you suspect an overdose, this is going to do, if it's not an overdose, this will not hurt them. That's the miracle of this drug is you can give it to anybody. I'm going to take it out of the packaging momentarily. I could stick it up my nose. I don't have any opioids in my system, but it's essentially going to be like spraying water up my nose. If there's opiates in the person's system, it'll take effect, knock the opioids out of the opioid receptors and hopefully start the spontaneous breathing. But if there's nothing, you're not going to hurt them. So this is the actual diagram that is included in the packaging. It is the easiest thing possible, and that's why they were so willing to give it to the first responders, because we really couldn't screw it up. It looks like an Afrin bottle or a nasal decongestant, and all you have to do, take it out of the packaging. If you really need to, you can look at the instructions, but it is simple as picking which nostril to go up, sticking it in, and it's a one-time use. So I hope the video actually captures it, but you just depress, and it's just an atomized vapor that shoots up a person's nose. And the goal is to attach to all the mucous membranes, and it's going to actually allow the drug to perforate into the blood system and then hopefully get to the brain, where it's going to change the results of the overdose.
Okay, so treatment. So treatment programs should be geared to the individuals. There are criteria for each level, but in general, there's individual counseling, there's outpatient groups. The groups could be 3 days a week, half a day, they could be all day. There's inpatient withdrawal management or detox facilities, residential programs, which in those two, patients will stay overnight. There are meetings, Alcoholics Anonymous, Narcotics Anonymous, Smart Recovery, Refuge Recovery are all recommended. Medication-assisted treatment, also known as medications for opioid use disorder, medications for alcohol use disorder, buprenorphine, which is Suboxone, methadone, and Vivitrol are the three main medications for for opioid use disorder. There are also medications specifically for alcohol use disorder. Prevention. So for protective factors for opioid use disorder, limited availability of the substances, availability of after-school programs, parental involvement, and early intervention once an addiction can start or potentially at risk of starting. Risk factors for addiction include genetics, about 50% risk with a first-degree relative, adverse childhood experiences, which includes several types of trauma, abuse, even witnessing trauma or abuse. A very strong risk factor, trauma or PTSD. Most of the people that I've treated over the years have a history of trauma or PTSD. Mental illness, including depression, bipolar, anxiety, and other mental health conditions. Home environment, lack of adult supervision, the availability of the substances, racism, poverty, and lack of employment opportunities are also risk factors for addiction.
And our last section is how to get involved. So this is just all of our contact information, HDAAC.org. We're also at 1750 Washington Street, so feel free to stop by. That is my number. Oh, my email's not up here. My bad. My email is Morrow, MOREAUZ @holliston.k12.ma.us. And then our social media pages, which you can usually find by looking up HDAAC, Holliston Drug, but they're HDAAC Coalition and Holliston DAC. And then specifically, this is our webpage for opioids. And there's a specific comment box where you could tell us your story, your ideas, just anything related to why you might have come to this website, come to this workshop, anything like that. We're always trying to get feedback from people directly impacted by opioids to be able to help us make decisions with the funds that we received.